As you know, डिजिटल इंडिया के लॉन्च के साथ ही हर सेक्टर में डिजिटल इन्वॉल्व उसकी जो प्लेटफॉर्म्स बनने शुरू हुए, डिजिटाइजेशन का जो एक दौर शुरू हुआ, उससे हर फील्ड में बहुत लाभ मिला है. ट्रांसपेरेंसी, एफिशिएंसी और भी बहुत सारे उसके फ़ायदे मिले हैं. सो हाउ एज अ प्राइवेट हॉस्पिटल हाउ वी कैन यूटिलाइज द ABDM एंड NHCX, ये प्लेटफॉर्म्स किस तरह से डिजिटल प्लेटफॉर्म हम यूज़ कर सकते हैं, तो उसी को हमने फोकस किया है Emerging ABDM एंड NHCX Opportunity for Private Hospitals, और इस सेशन को हम इसी रूप में आगे बढ़ाएंगे. ABDM aims to provide digital health, as you know, digital health ID to Indian citizens, connect hospitals and clinics via healthcare professional registry, and enable compatible electronic health records systems, allow integration also with personal health apps, and along with that, the National Health Claims Exchange, that is NHCX, is a central digital platform connecting insurance companies, hospitals, and policyholders, and it aims to replace manual claims processing with a digital system which is more efficient, making the entire process faster and simpler. So we are going to discuss different aspects of these opportunities through ABDM and NHCX. And in this session, we are privileged to have as a session moderator, Mr. Kiran Anandampillai, advisor NHA. I will request him to please come on stage. Mr. Kiran Anandampillai, who will be moderating the session. Along with that, we have with us in this session, before that I would like to share with you that Mr. Kiran Anandampillai is an advisor with the National Health Authority, focusing on digital health initiatives such as Ayushman Bharat Digital Mission. A telecom engineer and founder of the iDrishti, he has contributed a digital health infrastructure and policy through roles with UIDAI, Product Nation, iSpirit, and various government committees. So we welcome Mr. Kiran Anandampillai as a moderator of the session. As a panelist, we have Mr. Sayantan Chatterjee, who is Executive Director at PwC India, spearheads strategic initiatives and innovation in consulting services. With a prior role as Associate Director at KPMG India, he is renowned for his expertise in risk management and digital transformation. Mr. Mahesh Nagaraj is also in this panel. Sound क्यों चेंज हो रहा है आपका क्वालिटी का? साउंड शार्पनेस ज़्यादा हो रही है, इसको थोड़ा सा ठीक करिए, बैलेंस करिए, डोंट चेंज इट. Mahesh Nagaraj, Mr. Mahesh Nagaraj is a co-founded IHX, a leading data exchange and AI platform in India, and has over 26 years of experience in healthcare technology and consulting. He has held senior roles as HCL Tech Mahindra, and Microland. Mr. Mahesh Nagaraj. Mr. Kiran Gopal, Vaska Mission Director, ABDM, Joint Secretary, NHA. He is also with us. I will request him to be on stage as a member of this panel. Then we have Dr. Rishikesh Pai, President of Foxy and Regional Trustee at FIGO, is a leading expert in reproductive medicine with over 33 years of experience. He is the Medical Director of Bloom IVF Group, a professor at D.Y. Patil University, and has received 64 awards for his contribution to the field, including ISSRF Lifetime Achievement Award. In this panel, we have Dr. Rajiv Singhal also, who is founding member, managing director, and CEO of Marengo Asia Healthcare, brings over 24 years of healthcare experience and distinguished background as a general surgeon in the Indian Army. He is known for his leadership in establishing India's first EICU, the Heart Command Centers model, and his role in the turnaround of care hospitals. We welcome Dr. Rajiv Singhal also. Dr. Shuchin Bajaj, founder and director of Ujala Cygnus Healthcare Services, has transitioned from internal medicine to healthcare entrepreneurship, focusing on equitable healthcare access in underserved areas of India. He is also a board member of National NGO and advises on healthcare investments and innovations. And Mr. Shri Ram Ananta Sayanam, who is partner at Deloitte India, leads the digital government practice and space sector with over 20 years of experience in government tech and emerging technologies, previously a partner at PwC India, and is a leader in smart cities and blockchain of IBM. At IBM, he is a recognized thought leader on technologies like blockchain, IoT, and space. So let's welcome all the panelists along with the moderator of the session, and I will request Rizwan Sahab, our chairperson, and Dr. Atul Mohan Kochhar, our CEO, to welcome the panelists with a plant presenting to them. और इन सब का हम बहुत बहुत स्वागत करते हैं अपने इस सेशन में, जिसमें ABDM और NHCX जो emerging अपॉर्चुनिटीज़ हैं वो प्राइवेट हॉस्पिटल्स किस तरह से उसको यूटिलाइज़ कर सकते हैं, किस तरह उसका लाभ ले सकते हैं, और एक इंटीग्रेशन जो होता है उसमें पॉलिसी होल्डर्स का, हॉस्पिटल्स का और सिस्टम का, उसको बेहतर से बेहतर किस तरह से यूटिलाइज़ करते हुए हम पेशेंट सेफ्टी के लिए और हेल्थ सेक्टर में बेहतर गुणवत्ता के लिए और अच्छी क्वालिटी सर्विस देने के लिए किस तरह से अपने एफर्ट्स को आगे बढ़ा सकते हैं, जिस पर हमारे इस सेशन के हमारे पैनलिस्ट एक्सपर्ट्स from these fields, they will be discussing the topic, Emerging ABDM and NHCX Opportunity for Private Hospitals. आज के इस कॉन्फ्रेंस में हमने पूरे दिन सुबह से लेकर पेशेंट सेफ्टी से लेकर हॉस्पिटल्स, उनकी सेफ्टी, सिक्योरिटी, इंफ्रास्ट्रक्चर और डिफरेंट डायमेंशंस को हमने एस्पेक्ट्स को डिस्कस किया है. दिस इज़ ऑल्सो वेरी इंपॉर्टेंट एस्पेक्ट ऑफ आवर हेल्थ सेक्टर. सो प्लीज़ वी वेलकम ऑल ऑफ देम, all the dignitaries, all the panelists in this session with a plant, and I will now request the moderator of the session, Mr. Kiran Anandampillai, advisor NHA, to start the proceeding. But before that, we will have a group photograph, and after that, we will start the deliberations in this session. सभी पैनलिस्ट एक साथ ये ग्रुप फोटोग्राफ जो कि फ्रेम करके हम आपको देते हैं हर सेशन के आखिर में, जो आपकी मेमोरी के लिए आपके कलेक्शन में हमेशा रहेगा. और एक प्लेज जो आज हमने लिया है उस प्लेज को भी हम याद करते रहेंगे, ताकि हम एक क्वालिटी के साथ हेल्थ सेक्टर को आगे बढ़ाएं, पेशेंट सेफ्टी को आगे बढ़ाएं और इस देश में विकसित भारत का संकल्प, स्वस्थ भारत के संकल्प के साथ साकार हो. सो नाउ ओवर टू मिस्टर किरण आनंदपिल्लाई.
Thank you, and I think as we come to the end of a very long but interesting day, we'll try to keep this session fast and quick with all of the panelists. As introduced, what we're going to talk about today is the National Health Authority and IRDA has been working on the National Health Claims Exchange. And one of the key things that it is supposed to do is to make a huge change in how health insurance claims are processed by all hospitals. So let's try to understand a bit about what is this National Health Claims Exchange, what is the difference it's going to make to each of the private hospitals and players. So to start off, I'd like to start with you, Kiran Gopal sir. Kiran sir is the mission director for the Ayushman Bharat Digital Mission, which is the organization that's leading the development of the National Health Claims Exchange. So if you can tell us a bit about what is this thing that we call the National Health Claims Exchange, and what is this initiative by the government and how it's going to actually help private hospitals?
Thank you so much. So the Ayushman Bharat Digital Mission that aims to foster a digital health ecosystem in the country is an initiative by the government under which we are creating the public infrastructure that can help in digitizing the healthcare ecosystem. So as part of this, we are creating registries for the citizens, for the providers, that is the doctors, and the hospitals. Apart from that, there are 3 gateways. One which we call the Health Information Exchange Consent Manager, which is the gateway that will help in seamless exchange of information, that is health information between 2 hospitals or an individual's mobile application with records that are present in another hospital with the consent of the data principal, that is the citizen. The other one is the Unified Health Interface, which is like the UPI for health, where you can use an application of your choice as a citizen. Your provider can use an application of their choice as a provider, but still you should be able to discover each other, find a service, book a service, avail it, and pay for it. The last one that we are talking about right now is what we are calling the National Health Claims Exchange. Today, if we take a typical hospital, a 20-30 bed hospital, when let's say 3 different patients come to them with 3 different insurance policies issued by 3 different insurance companies, as of today, the hospitals have to visit each of these portals separately, or they have to go through an intermediary who is doing this job for them. And at the end of the day, there is this dependency on how good the systems are on the other side in the insurance to get updates, to get information on what happened to a particular claim, what is the current status of the claim, whether the payment has been done, etc. Another thing that happens here is when a patient comes, when you are registering the patient for the first time and he says that I have X insurance policy, the inclusions and exclusions are not very clear because they are not codified that way. And lastly, once treatment is given, we all know that once a patient gets admitted, treatment is given. In the morning, the regular doctor comes for rounds and says, let's say around 9 o'clock or 10 o'clock, good, you're good to go, good to discharge. But we all know that the actual discharge happens somewhere around 3 or 4 p.m. What happens between the 10 a.m. and 4 p.m. is a back and forth between the hospital, the TPA and the insurance saying that ये included है, ये included नहीं है, इसकी eligibility है, उसकी eligibility नहीं है. And this is adding to the additional cost that the patient may have to pay because that additional period may not be covered. Plus the frustration of the whole waiting leaves a very bitter taste in the mouth of the patient who after getting treated is not very happy, and also in the hospital because they are also losing that bed because it could have been used for somebody else. So now in order to simplify this, in order to smoothen this, NHA, the National Health Authority, an attached office of the Ministry of Health and Family Welfare, Government of India, teamed up with IRDAI, the Insurance Regulatory Development Authority of India, to develop what you call common claim standards and an electronic claim, format, and then a gateway as part of the Ayushman Bharat Digital Mission, so that a hospital can use their own application, one single application, which could be their own HMIS system or a specialized claim processing, claim entering system. And they use only one system. The claims go to the exchange or the gateway. The gateway reads the information which hospital it is coming from and which insurer it has to go to, and the claim information is forwarded there. The beauty of this whole thing is everything is electronic, everything is digitized, and each product that we know of, like for example, insurance company X has a product for let's say anybody who is 30 years or plus, covering XYZ diseases with an overall cover of 1 crore per annum or whatever overall. That can be codified into what we call a plan object, so that any inclusion, any exclusion is known well in advance at the time of registration. There is no confusion as to what is to be treated and what is allowed and what is not allowed. And then the entire system is built on open APIs. We use the common international standard for information exchange called FHIR, the Fast Healthcare Interoperable Resource. With this, there is clarity, there is visibility, and there is interoperability of claims. So this is what the claims exchange is about. And as of today, as we speak, more than 38 different entities, which include 27 insurance companies, all major TPAs, 8 of them, and 4 digital companies which help hospitals in submitting claims have been onboarded. And the entire PMJY IT system for 18 states is currently running on this. So this is in brief about what the claims exchange is.
Thank you so much, sir. I think it's fascinating to hear that we're going to see some serious change in how claims is processed. But I would love to get some perspectives. Dr. Rajiv Singh, if I might address you, sir. You're running a large tertiary care hospital. I'm sure there's quite a few insurance claims that you're currently processing in your hospital chain. Could you share with us a bit about, what are the customer expectations on these cashless claims when they come in? What percentage of your patients really use cashless? And what are the challenges with all of these multiple TPAs, insurers that you're dealing with today? What are the challenges you see today? And what's your sense from what Dr. Kiran Gopal is saying? Do you feel it's going to effectively address those problems, or are there still other areas that should also be looked at?
Thanks, Kiran. First of all, thanks NABH for organizing a very interesting and important session on insurance, because I think all the hospital operators who are sitting here, if you look from the patient satisfaction aspect, the discharge time which takes for insurance is the most crucial, and it's the Achilles heel for all the hospitals. No hospital has been able to crack this Da Vinci code of insurance discharge in time. I think that is one of the key reasons people still shudder to get the insurance done, because it's like Hotel California, you can check in, but checking out may be difficult. Okay, so I think having said that, if I have to just illustrate, and I would always say that the initiative which the government has taken to create that exchange and also trying to enforce that all the discharges should be done within 3 hours of the final bill submission is a very, very welcome step. If we can achieve that, I think it will be utopia, and our endeavor should be that we should get to that documentation and getting to that stage where patients can go seamlessly from the hospitals. I think that will be the ultimate thing. Coming to our experience, if you look at Meringue hospitals, I think our 46% of our revenue comes from insurance patients, which amounts to 38% of the patient and 46% of the revenue. The challenges are huge on operation. In fact, the people on the ground, I would say, they are feeling no different than the rest of the hospitals, right from the admission time, from the pre-authorization, the sanctions which are given, and the final bill, and then suddenly the sometime articulation that yes, this pre-auth doesn't stand good, and then you have to pay and claim that. It leads to a lot of, I would say, dissatisfaction amongst the patients. So these are things. Even after the cashless is done, I think the biggest challenge today with all the hospital operators are facing is about the cash flow management, getting money in time, and the deductions which are there is also a cause of concern. TPAs are getting much stronger in the role, and I think I would say that somewhere down the line, TPAs also have to work as partners with the healthcare providers. Sometime it happens, and I'm sure everyone who is sitting in the room and running the hospitals, they come across a situation where they would suddenly say that because of the bills which were audited 3 years back bills, we want to take off your hospital from there. So I think there has to be some logic, there has to be justification. It cannot work on the principle of unilaterality where one person is given a chance to basically take off the hospital. I think this is against the I would say the right justice law. You can always seek explanation, ask people to basically represent. If you are not satisfied with the representation, then you take a call. But I think do not give a right to anyone to arbitrarily, just because you are in a governing position, you can do that. So I think the insurance sector, on one side, we are trying to involve more people getting into the schemes, cashless, good for patients. But I think the other side ecosystem also has to mature to a level until both the ends start talking to each other. The patient's satisfaction and ultimate objective of giving patient the best care and hospitals become a best provider will not be achieved.
Thank you so much, sir. I think while technology can address some of the problems that you state, I think there is beyond, I can see many things beyond technology that will also need to be solved to go there. I think I would like to just get another perspective from a hospital player. Suchin, if you can, you run part of Ujala Cygnus, almost 22 hospitals across 16 cities. And I think many of them are in tier 2, tier 3. You've been also working with a lot of the government schemes. So apart from private health insurance. So you're working with, like, I would say, a mixed set of insurance claims. So what has your experience been with cashless claims, and also from a tracking reconciliation across all of these different, what are the challenges that you see, and do you see technology being able to come in and solve for that?
Thank you very much, Kiran, and many thanks to the NABH team led by Dr. Atul sir and Rizwan ji here for organizing this wonderful event. As you correctly pointed out, we run hospitals in small towns, and not some of them, all of them are in tier 2, tier 3 cities, because that's where we feel the real need is. And NABH has actually helped us a lot, hand-holding us from the very start of our journey to make sure that quality was integrally built into the system. The ratio of cashless patients obviously has been increasing a lot. So when we started out, you had to make each and every file manually, and that file had to go through at least 5 to 6 manual interventions to finally, get the payment in. And of course, as you know, every time a manual intervention happens, it leads to delays. Some, are valid, some are completely invalid, but there are delays. So when Ayushman was launched, I think we were the flag bearers. We have always been the champions of Ayushman Bharat and PMJY, and we were very happy that an entirely faceless, fully tech-enabled solution was coming in. But as you pointed out correctly, it's not just technology that has to be solved for, right? So right now, we do almost 50 to 55% of all our patients are paid for by third parties. Still, we have around 45% patients who pay out of pocket, which is unfortunate for the community, I agree, but I feel that even with 55% third-party payers, we are struggling to manage our cash flows. So if we were to get to the utopia of zero out-of-pocket patient payments and make sure that nobody is falling below the poverty line due to healthcare shocks, it will be very difficult for hospitals to manage with the current scenario that we are running in, right? Almost we have 1/3 of our annual revenues are stuck as receivables even now. And initially, as I said, Ayushman was a beacon of hope that, the technology would make sure that the payments would be in time. But unfortunately, 28% of all our receivables are now due to this one agency, which is a huge number for us. Because if you're running the show with very low prices, which we try to do, the cost of your money is very high, right? India, you cannot raise capital debt at less than 12 to 13%, and equity is like even 25 to 30%. So if those are the interest rates you're paying and your capital is stuck for 300 days, 180 days, 200 days, then the operations become completely unviable. The ecosystem is such that there is a lot of mistrust that has been built between the payer and the provider. See, it is correct that the payer will ask for more and more controls, more and more price drops, more and more efficient operations. That is their right to do it. The provider will always ask for more independence, more discretion. This is how we want to do it. These are the protocols we follow. That will always be there. But the mistrust that has come in is actually very counterproductive to everything. We are forgetting that we are both here to serve one common cause, that is to provide the patient the best care. With the back and forth between the payer and provider, we are forgetting about what is needed by the patient. It is like, imagine a surgeon and an anesthetist standing on the OT table and fighting all the time. No, this is how you do it. No, this is how you do it. The patient is suffering, right? The surgeon and an anesthetist both need to recognize that it is for the patient that both of them are working. So we have to build a lot of trust into each other's operations. We have to make sure that these delays are somehow taken care of, and that is why, again, I am hopeful with the HCX coming in. I think good actors will be rewarded, bad actors will be weeded out very quickly, and I am sure that we will build a lot of trust. See, it is the same as shoplifting, right? Only 1% of the people are actually going into stores and lifting the goods away. But the amount that you are paying, the last estimate was, I think, the safety equipment that is onto those clothes, that is tagged onto each and every cloth, and the sensors at the gates to make sure that you don't carry out stuff. I think the last piece was $8 billion of expense every year, just to prevent shoplifting, which only 1% people are engaging in. This is what is happening with the healthcare industry now as well. If we can weed out the bad actors quickly, we can save a lot of money, we can save a lot of time, and we can build a lot of trust into each other's operations if we understand that we are working for the same cause, working for the same patient, making sure that the patient is benefited a lot.
Thanks, Sachin. I think interesting point in terms of, definitely I think tech can help in providing markers in terms of data to figure out who can we trust more. I mean, there are many approaches that people have tried, including, providing ratings based on historic, this one, and that can probably also help change some of the cash flow issues. And there are other areas that I think tech can probably work on that. So interesting feedback in directions where we want to go. I want to just switchly quick the conversation to Mahesh. Mahesh, you run a tech startup. Your IHX is one of the players that has integrated with the new National Health Claims Exchange. And you are in the business of trying to help hospitals make claims more smoother. So what is your viewpoint on how NHCX is going to change the claims game, and how do you think you will be able to help private hospitals and other players like you help private hospitals make a difference in this?
Yeah, thanks, Kiran. And congratulations to NABH on such a great event and such a great participation. So I think if I look at today the insurance industry, we are talking of annually, as of today, 2.6 crore claims only from the private side. I'm not even talking the government side, getting processed. And with the kind of growth that is being experienced by India, right, there is going to be, the insurance industry is just going to go through the roof. So this is here to stay. So the question then comes up is that how do we collectively work together, on a platform that will smoothen this whole process? I think everybody knows the challenges, right? Whether it is in terms of the response time, whether it is in terms of deductibles, whether even identification of non-medical expenses, etc., etc. So there's a series of problems that is there. And as the patients become more tech savvy, their expectation is, why can't I get an instant answer for anything of this nature, right? So what NHCX is really enabling or setting out to enable, if I look at it from a vision perspective, is basically to say that, okay, can I just get an instant adjudication of a claim? I submit a claim, I just get an answer back saying that, yes, this is approved, and without having all the problems saying that it got approved at pre-auth level, but got rejected at the discharge level. It should not happen, all of those configurations, right? And one of the things that I think, at least I am very bullish with this particular platform, is that if I just take 40% of the claims today are primarily related to packages, whether it is cataract, whether it's dialysis, whether it's chemo, it's packages which are very defined, the limits are defined. Maternity as an example, even though you may have a 1 crore cover, you may still have a sub-limit of say 2 lakhs or 3 lakhs, which are covered there. I don't really see a reason why it should take 3 hours, 6 hours to basically adjudicate that particular claim, right? And one of the things that's great that is coming out of this whole platform, and as you possibly would experience it as many of your hospitals will start looking at it, is the fact is there's something called as an insurance plan object that gets created, right? Where you will be having a visibility of the complete, what is the kind of tariff, what is the limits that are being available for that particular patient. In some cases, the hospital may not even want to start the claim journey, because if there's a cooling period, why there are frustrations at the hospital level? You start a claim and then suddenly response comes back and saying that, okay, the waiting period is 2 years, right? And you've gone through the whole journey of making a claim, submitting a claim, and then coming back and then saying that this is not working, right? So I think there is a lot of those elements, right? Whether it is around tariff mismatches, whether it is in terms of looking at, queries, it's a very big issue in terms of you send a claim and then come back a query saying that, okay, this document is not available, right? So I think what we are trying to do as a tech provider helping out in this whole journey is the fact is, how can it be very smooth for the hospitals? Just to give you an example, today under 10 minutes, if any hospital wants to enable or empanel on NHCX, can come to IHX and under 10 minutes you will be on NHCX. And today we have got close to about 400 hospitals which have used IHX to onboard onto NHCX today. right? One of the other things that we are also building, working closely on the other side, because it's just not on the provider side, but also working on the insurance side, is to basically say that, okay, how do I ensure that I'm able to reduce the query to the minimal? From almost like 5.5 transactions that happens on a claim, can I just basically bring it down to say 2.5? What does it take towards that? What is the journey that comes in there, right? How do I create a visibility of the deductibles so that you don't land up in surprises later on at the time of settlement? So I think there are fundamentally, when you start looking at the value chain and start building up these blocks and then trying to see that what we can possibly solve for, I think there will be a great opportunity that is being set out today in terms of making this happen. And I think it will be very, very useful for the hospitals, because I think somebody mentioned that today for the 50 odd insurance and TPAs, where you have to go to multiple of these portals, you can just now use one, and everything else at the back end, NHCX takes care of it, right? So there are a lot of these advantages that basically comes through in terms of making it as seamless as possible. And I think at least we are very sold. I think this is a very significant transformation journey. And I think if we work together collectively, I think this can really be a game changer, putting the patient at the center of this whole thing. And also through that process, help the hospitals, whether it's around effective discharges, whether it is in terms of, pushing through, instant discharge, instant approvals. For me, I think that's a very big nirvana point to say, get to the point of saying that, okay, can I get to an instant discharge for any of these cases?
Great, thanks Mahesh. And I think my big takeaway is that, with NHCX, we are really looking at a new era, hopefully of instant gratification, instant approvals with things like auto adjudication coming in. I would like to just switch topics, sir. Kiran Gopal sir, back again. Apart from NHCX, ABDM has also been promoting UHI. I think you briefly spoke about it in your opening remarks. If you can tell us a bit about what is it that private hospitals can potentially take benefit from UHI? How do you think it will actually help their work or their business? And what is a bit more about what is UHI?
Thank you. In fact, before I speak about UHI, I think what the panelists have spoken about NHCX also gives us more confidence about what we are going to build and what we are trying to take up as a major component of digitization. Similarly, UHI is one entity or one gateway that aims to move away from that siloed approach. I mean, today you want to do teleconsultation, you have to be on that app, your provider has to be on that app. So this eventually can create these silos which A, stifle innovation, and B, create those entry barriers for newcomers. So the whole objective of the unified health interface is to move from a siloed approach to a network-based approach. The simple idea is, if there are 10 people and each one of them was to connect with each other, there have to be sigma 9 connections, right? 9 plus 8 plus 7 plus 6 plus 5 and so on. With the network approach, everybody just connects once, and then everybody is visible to everybody else. And another interesting thing about UHI is, it doesn't matter whether you are a big player or a small player. So if you are a new hospital or a new small single doctor clinic, let's say for example, and if you have onboarded onto the unified health interface, and let's say you are let's say you started a new small hospital for children, a pediatric hospital. Today, for you to be part of a larger network, there are certain barriers. There would be not many people would know about you. Whereas with UHI, you would be equally visible to a customer as a large hospital is. So I think that the democratization and that network approach actually makes sure that newer and newer people come. And our approach in UHI has been that the results will be shown in a very transparent manner. The pricing will be shown, and ultimately it would be the choice of the consumer to choose which of the service providers he or she wishes to avail the service from. So that could be dependent on factors such as cost and also quality. And also the ABDM backbone and the ABDM framework comes built in with UHI. That is, you use your Aadhaar to access the professional there on the other side. The doctor and the hospital are also registered on the professional registry and the facility registry, so that you know from the very beginning that you are dealing with a trusted entity. I mean, if somebody there at the other side says, I am an MBBS doctor, that is verified by the council concerned that that person is actually an MBBS doctor. If a hospital says, I am so-and-so hospital located at so-and-so place, that has been verified by an authority to say that, yes, this is his hospital. So that way, this whole trust factor also comes in. So therefore, the transactions become much more, easier and it becomes more transparent in a way. So I think by bringing down those entry barriers, by promoting innovation, by promoting better quality of care, by bringing in digitization, I mean, ultimately, the record that you get after a teleconsultation through UHI, you get it on your PHR application, the personal health record application. So certain things, UHI, by being part of the larger ABDM ecosystem, enables this digital interaction, this digital communication between the payer and the provider and the patient, so that in a trust-based environment, so that the overall experience becomes much more smooth. And for new private players, this is a real big benefit, because we are trying to break those silos, we are trying to bring down those barriers so that everybody is treated equal, and any new entrant also has that equal footing as an already established entity. So that's what I think is one of the big values that UHI brings in.
Thank you, sir. Actually, I was chatting with Dr. Rishikesh in the back room, and he was explaining to me, sir, you have been president of Foxy, almost 40,000 plus, I think, doctors in the association. And he was telling me that there is two types of kind of doctors. So I want him to explain, sir, what's your experience with, while, this panel has been talking about digital, and a lot of digital, I think, you gave me a little bit of a sticker, a reality shock in actually how doctors look at digitization and using digital tools. Maybe if you can share your experience briefly about how you are seeing the doctor ecosystem adopt new digital tools that we are all trying to bring and promote out here.
So thanks, first of all, I'd like to thank Mr. Rizwan, Dr. Kochar, Dr. Poonam, and all the NABH team, Dr. Pompey from MSD and Satwa team as well, for getting our checklist done. So we are an organization of 44,000. It's a very large organization, one of the largest medical, with 277 societies, very hierarchical, structured organization. A lot of projects are going on. And this is, of course, a new phase. As I was telling him that we are all, there are two groups in our organization, 40 plus group, which is more, not so much digital savvy. We get confused about, trying to get adapted to the digital space, and we will have to have a different approach to that 40 plus group. If they are resistant, we will have to create more support system for them in terms of trained personnel who will do their work for them. I do a lot of digital work. I do consultation. I do a lot of technology. All the time I'm consulting on the net. I treat on the net as well. And the other thing what I would like to tell you is that in our gynec field, there are again two parts. One is the people who are about let's say about 60, 70 crore people who are already covered by the government. When I was Secretary General of the Federation in 2016, Ayushman, the Pradhan Mantri Surakshit Matritva Abhiyan was launched. That's again an insurance claim, and now the Suman system, which is there, is a fantastic system. But in this whole process, there's another 25, 30, let's say 10 crores who are well off, and 20 crores who are confused souls. They are neither here nor there. So they are the people who no one is taking care of, and they are the actual drivers of the Indian economy as well. So we will have to take care of their health needs also. And just like we have a cylinder system also, the government should say, let them say that we don't want the health scheme. You as a democracy should give the health cover to Ayushman Bharat should be for everyone. Then it is my right to say, I don't want it, I will pay it from my pocket. So this is what one thought process I would like to insert into the mind of the government. The second is that most of the procedures in our line are not anyway covered. Pregnancy in private not covered so much. Some insurance people are covering it. The other day I was on a panel and someone came and said, sir, IVF, because I'm an IVF person. They said, sir, IVF, we are now started covering it. So slowly the covers are coming, but they are still diffuse. But I'm very excited by this kind of platform wherein we'll be able to access everything and integrating. And we will have we are already integrated in our language, in our nationalism and all that. And let's hope that at some point in time, we'll be integrated in our healthcare as well. We are still not integrated. There are different groups of people, and we at some point will have to integrate those groups.
Thank you so much. And I'd like to just, for the last question on this panel, Shri, I think you've been a consultant working in GovTech. You're listening to all of us talk about various technologies that are potentially going to change the world. What's your view of how this is actually going to impact, healthcare providers, and where do you see the opportunities for private players?
Well, thank you. Thanks, Kiran. And perhaps as a consultant, I have the last word in the panel. We talked about a lot of things. Some of the keywords, if you look at it, it's perhaps applicable to all sectors, more so for healthcare. We talked about predictability in service delivery. We talked about trust. We talked about the network effect of bringing everybody together. We talked about interoperable data exchange and creating registries, what Kiran sir talked about in ABDM. We talked about discovery and fulfillment of services, again, UHI, a model that Mr. Kiran Gopal talked about. Now, what all of this would result, in my opinion, is a coming together of an ecosystem of people or participants keeping the patient at the center, like Dr. Bajaj said. And when we are keeping the patient at the center for every single decision making, be it the provision of insurance, or be it providing of the services, or giving freedom to the patient to discover and choose the kind of services he or she wants at will, that is going to significantly disrupt the way the healthcare services is going to be done in country. And the other word that I heard used, which I completely agree with, was democratization of services, which means we will not be held hostage to a single closed system for service delivery, which is happening in many of the developed countries. India, perhaps in the healthcare domain, will lead with an open system, open standard, interoperable approach for service delivery to patients, which perhaps can be a role model or beacon for the global south, like was talked in the G20 meeting. So exciting days ahead. I know we have only scratched the surface, but the speed at which adoption is happening, I'm sure perhaps in the next conference, there will be a lot more success stories, and perhaps 1 or 2 success stories where this Indian model has been adopted in perhaps Africa, Southeast Asia, or the Caribbean.
Thank you so much. I think we are almost completely out of time, so with that, I'll bring this panel to a close. I'd like to thank all panelists for coming in, participating, sharing your valuable thoughts today on this new digital generation. Thank you.